next session?
Yes, definitely, madam. I think sir is available.
Yes.
Yes, sir.
Okay, now I would like to introduce our next eminent speaker, Dr. Gyanshankar Mishra, sir.
Excuse me, ma'am.
Yes,
I
sir.
think sir is not available yet. Just a minute, let me check that.
Yes, sir, please.
Yes, sir is available. I'm making co-host.
Okay, sir, please.
Yes, done.
So, Dr. Gyanshankar Mishra, sir, he is MBBS, MD, DNB, MN, AMS. Sir has completed his MBBS in 2004 from D.Y. Patil Education Society, Medical College, Kolhapur, Maharashtra. Sir is MD in respiratory medicine. He has completed MD in 2009 from Government Medical College, Nagpur, and DNB in 2010 from National Board of Examination, Delhi. Sir has 15 years of teaching experience, and currently he is an associate professor in the Department of Respiratory Medicine, Indira Gandhi Government Medical College and Hospital, Nagpur. Sir is an international member in core working group of the End Tube TB Transmission Initiative. Sir has bagged various awards such as Best Young Researcher Award 2019 and Best Young Teacher Award 2015 awarded by Grabs Education Trust, Chennai. Best Research Paper of the Year award by Staff Research Society, Indira Gandhi Government Medical College, Nagpur. Research Publication Award by Maharashtra University of Health Sciences, Nasik in 2025 for research publication. Sir is a true academician with strong interest in research and publications. His publications have led to incorporation of policy decisions by Government of India in the TB elimination program. To his credit, Sir has more than 50 international publications. Thank you so much, sir, for your graceful presence. And now I request Sir to proceed with the session.
Sir, namaste.
Namaste. Sure.
Thank you so much for accepting our invitation.
At the outset, I would like to thank the organizers, especially Professor Khatib, for inviting me. Is my screen visible?
Yes, sir.
Okay. Sure. So today the topic that we'll be throwing a light on is current roles and future perspective of artificial intelligence in respiratory medicine. So being a chest physician, respiratory medicine is my domain, and over the last decade or so, AI has really come up in a large way in healthcare sector. So respiratory medicine is no different. It is a subspecialty of medicine where we look at respiratory disorders mainly related to the lungs. So in this short session, what we'll be doing over the next 90 minutes is this is a brief outline of that. First of all, we'll be having an introduction to artificial intelligence in respiratory medicine, where we'll be seeing how what is AI and how it can be integrated into respiratory medicine overall. What is its current role in imaging and diagnostics? There are various softwares. It is used in bronchoscopy, fun, but there are various diagnostics and therapeutic uses of this. Then there is something called AI-assisted bronchoscopy. Now this has come in a large way. We'll see in detail in the lecture. Basically, it enhances the precision and reliability of the procedures. Then tuberculosis, this is a very big disease in our country, and today the government of India and all of us, we are trying to tackle this disease and trying to eliminate. It was due to be eliminated in 2025. but still we have not succeeded, and we hope to conquer this disease soon. So here we will have a look at various aspects like symptom screening, diagnostics, and these are the AI designed antibiotics. Now this is a very novel thing that has come up. When AI in airborne infection prevention control, this in respiratory diseases, airborne infection prevention control is very important. Like we have seen in the COVID pandemic, the main risk of COVID was not due to its mortality, but it was due to its fast spread. So in any respiratory pandemic, fast spread is very dangerous, and therefore infection prevention and control, they take the prime importance in tackling a respiratory pandemic. Then there are certain risks associated with de-skilling of AI that we'll see. Then we can use it in various research statistics. We'll see it with examples. And then finally, conclusion. So let's start. So respiratory medicine or pulmonology is a medical specialty focused on diagnosing and treating diseases of the respiratory tract. Respiratory tract is a part of our body which includes organs like lungs, airways, and other related organs. And the diseases that we primarily see in this specialty are asthma, COPD, infections like TB, and occupational lung diseases. Now, artificial intelligence, it combines computer science, data, and problem solving to enable machines to perform tasks that normally require human intelligence. So the role of AI in any of the healthcare settings is to perform tasks that normally require human intelligence or that require the humans to think. So wherever it replaces or helps in thinking or decision-making process, then we can call it artificial intelligence. It is increasingly integrated into respiratory medicine for imaging, diagnostics, treatment planning, and public health surveillance. And also important is enhancing accuracy and efficiency. So let's start here. In a big way, the role of AI is coming up in imaging and diagnostics in healthcare sector. So there are various softwares. Now this is one of the softwares, Genki AI. This is an AI-powered lung health screening tool developed by Deep Tech. Genki leverages advanced deep learning techniques, including attention mechanisms, which help the model focus on most critical regions of chest X-rays for accurate TB detection. So what this AI does in radiology is that it picks up abnormalities on chest X-rays, and it gives us a quantification that what likelihood is there that this is abnormal and what are the likelihood of various differential diseases or differential diagnosis of these abnormalities. So as human beings or radiologists, they give a detailed reporting, but here AI will give you the probability based on the learning or the data set that has been fed into the AI. So any AI model is as good as the data set that has been fed into it. If the data set is vast, enormous, then it will perform better. And if the data set is not that good, then it will have errors. Now this is again another lung tool in respiratory medicine, lung vision. Now what it does is it uses artificial intelligence to transform images from any 2D CR to real-time 3D images. So it transforms a 2D image into a 3D image. So it will give you the depth for navigational bronchoscopy procedures. We'll go later on and see what is navigational bronchoscopy. But at this stage, bronchoscopy is one of the procedures where we go into the airways. So bronchus is the airways. So there. So bronchus is our airways, and in bronchoscopy we put an endoscope in the airways and see if there is any abnormality in the bronchus or the lungs or the respiratory system overall, which is accessible to the airways. What we can do there in the bronchoscopy is we can take some washings, some respiratory samples, we can take some tissues or biopsies, and we can also do some septic procedures. So this is a diagnostic as well as septic procedure. So here AI or lung vision or this software, it helps us to get a real-time image or a 3D image, and it will help us in navigation. So it will help us guide in the airways where we can go. We'll have a look at in the later slides. So the usually conventionally we use the Siam, which has a high radiation, and this system uses minimal radiation and has up to 95% diagnostic yields. So in 100 patients, in 95 patients, it will give us a diagnostic yield. This system improves precision and reliability of lung nodule biopsies, which can lead to earlier cancer detection and improve the patient outcomes. So it can help us take targeted biopsies from lung lesions and help us in an early diagnosis. Now here we can see on the left side you have a lesion, and first I have a look at the right side. So in the right side there are various CT scan images. Here you can see that there is a red cross. So this red cross, this is a nodule. Usually when we read a CT, black thing is the air, and anything white, usually in the lungs, that is abnormal. So here you can see the black thing, this is the lungs, the air, and white thing, this is something solid. So we have to target this. So here the CT scan or the artificial intelligence, it will help us target. So we have put the target, and then on the left side now you can see that this is a yellow area. So this yellow area is a targeted lesion, and it is giving me the pathway. So I follow the pathway, I go through the bronchoscope, and this is a Siam guided biopsy. So here the needle is removed, and then you can take a biopsy and then again go back. So this is how artificial intelligence, it helps us in decision making. That this nodule, this is present on a Siam here, and then we can do a targeted biopsies. Now, if this technology was not there, then it would have been very difficult. So this is how it helps in navigational or bronchoscopy or targeted biopsies. Now this is again a new technology where a remote bronchoscopy means if I am sitting in Nagpur, I can do something in Mumbai or Delhi or in some remote area, like say in Gondia, where human expertise is not available. So here we can see, now this is a very recent paper, this was published on 30 July 2025. So this was actually a procedure done on porcine model. So what they did is in a remote hospital, the bronchoscopist was there, and from there he did the bronchoscopy, having a look at the images. And then here at a distant place, let's say the 200 to 300 kilometers or 1500 kilometers away, now there was a dummy patient or a porcine model, and there a robotic arm was used. So here the bronchoscopist, he was doing a bronchoscopy, having a look at this screen, and there from the bronchoscopy arm or the automated arm, AI was giving the decision, or AI was helping in the decision that yes, this is a foreign body, this is located in the left main bronchus, now we are supposed to go there. So with AI assistance, the foreign body could be removed. So now this is a major breakthrough. That sitting here, I can do a foreign body removal from there, diagnosing a foreign body, and then it will give me a track that okay, you are supposed to go here, I'll do it, and then it can be a therapeutic procedure. So this is a really landmark study that has been published this year. So why this is groundbreaking? Because here actual no CT scan is required. I can have a look at the radiological images. This is very economical as of now. It is not that economical, but yes, in coming times it will. We can think of the cost coming down. And this is again a very good example of AI-human collaboration. And in some domains, it outperformed the experts in coverage of safety. So now here AI-human integration, it is outperforming even the experts. So now this is coming up in a big way. Another thing is chest X-rays. Now chest X-rays routinely used. Now this is the most first line investigation for screening any respiratory disease. So currently autonomous artificial intelligence for chest X-ray pathology detection in India is officially used in the government sector. Now these models are trained on a huge data set of 5 million chest X-rays. It detects and segments up to 75 pathologies. It achieves 98% precision and 95% recall, and it is deployed currently in 17 healthcare centers. It can process 2,000 X-rays daily. So this is being used in government sector. And what I can see from here is that the usage will be going up only. This will be especially useful in the remote areas, like in remote areas where radiologist is not available. And there, if we do a chest X-ray and a reporting is available, then there will be no delay in diagnosis. So remote areas where specialists are not available, there this technology is definitely going to be of help to us. Now, what is our experience? Now, at Ih&Ms in Nagpur, we have started a Nidan TB project. That is nothing but we'll be screening almost 1 lakh population of the whole Nagpur population, Nagpur city, for tuberculosis in high-risk population. So, in this project, we are using artificial intelligence guided chest X-ray diagnosis or screening of tuberculosis patient. So, on the right side, you can see that there are 2 models. The first one is the original chest X-ray, and the next one is the reading by artificial intelligence. So you can see this is the original chest X-ray as a manual. So normally in manual reading, what I will say is that okay, there are abnormalities detected in the right upper zone and in the whole of the 3 zones of the left side. And now let us see what the AI does. Now AI pinpoints that these are the abnormal areas. So on right side, it has identified a patch. On the left side, it has identified 2 patches. And finally, it is giving a diagnosis that tuberculosis, yes, it is suspected in 89% is the probability of this having tuberculosis. So right now, it is almost changing the screening procedures in the field. Previously, this used to take almost a day, that this will be read by the clinician or the radiologist. Reporting will come. Then when the reporting comes, then the patient will be called for the next step, sputum examination or diagnosis, and then TB will be diagnosed. So right now, this is giving instantaneous results in the field. Within 5 minutes, the reports are generated. In half an hour, everything is there, and the patient can be screened for other investigations at the field only. So this is really a game changer in the field. This is just to converse all of you that what a traditional computed tomography or CT scan of the thorax or the chest normally looks like. So there are 2 types of CT scans. One is the conventional CT. So here you have the black areas and the white areas. So this is the right lung, this is the left lung, this is the heart, this is the trachea, okay, and these are the airways. So here this is the conventional CT, and this is high resolution CT. So here the slices are very thin, and then therefore you can visualize the lungs in more detail. So here there are abnormalities. So this is how a conventional CT or HRCT looks like. Now here also artificial intelligence has been integrated with various technologies. So let's have a look at how the AI enabled image analysis in CT scan thorax works. So it converts a normal CT scan into a detailed image as per our requirement. Like in the first picture, you can see anatomical segmentation. So it gives us various pulmonary arteries and veins. So various pulmonary vessels or the arteries and veins, these are the blood supplying units. So various blood vessels, we can see the blue ones are the veins, the red ones are the arteries, and you can see here. Okay, so it gives us a pulmonary vasculature, a detailed picture. If I want a detailed picture of the lobes and segment, so it can give me that also. So this is the right lung, left lung. Right lung has 3 lobes, left has 2. So it is giving me the detailed segmentation. If I want that, okay, my patient is a smoker, so hyperinflation or air trapping, can you give me that? So yes, that can give me that also. So based on various color coding, it can give me different areas of how the patient has obstructive airway disease or air trapping or hyperinflation or smoking related lung diseases. It can give me anatomical mapping, like if there is a lesion or if there is a foreign body, if there is a suspicious nodule, how do I approach it? So it will give me an approach pathway, and following that, I can reach the lesion. Now again, it can be used for quantitative assessment, like how much of the lungs are involved. So it will give me a color coding, like this is the color coding for emphysema severity. Emphysema is nothing but presence of more than normal air in your airways and lungs. So your lungs are hyperinflated. So this is mainly due to smoking, air pollution, biomass fuel exposure. So emphysema is that. So in those smoking related lung disease, how much air is there, how much hyperinflated my lungs are, it will give me that quantitative assessment. And this is chronic perfusion defect. Perfusion defect is nothing but the difference in blood supplies to the normal lung units. So here you can see that in the right upper lobe, this is black. Rest of it is perfused. Blue, red, everything is there. But here, in the right upper lobe, it is black. So that means there the blood supply is not reaching. So usually the blood vessel going there must have some clot or obstruction or what we call the pulmonary thrombosis or embolism. So these are the different ways in which AI can be used in image analysis of conventional CT scan or HRCT scan. Now, this was one of the projects in which I was involved as a co-guide. So here the students, what they had done was they prepared one prediction model for lung cancer. So almost a data set of 967 CT scans were there. They applied different models. Now this is convolutional neural model, ResNet, exception, and these are the different models. So a training was done, and after training, then the data set was tested for on other cities for its prediction accuracy. So it was just a learning project, but still the students were able to predict it with quite reliability. Now the problem in this CT scan image analysis is that one CT scan has almost more than 100 different slices. So the amount of data is very huge, volumetric. So ideally you are supposed to capture all the slices or all the images in a CT scan. So that is a single CT scan. So the computer model or the AI model, it is to be trained in a huge amount of data set. Now that is the challenge here. So here a collaboration of a very a center where such huge amount of patients come and technical expertise of maybe some engineering department where we can collaborate, then we can come out with very good lung prediction models or lung cancer prediction models. So the only problem in such developing such algorithms is the data set. Here the students said they had taken ready-made data set that are available. But ideally, we are supposed to take a data set from a hospital, take a histopath report, histopath confirmed report, and then feed it into the models, and then the precision will be really high. So this was the example. So right on the left side, it was a normal CT scan. The model predicted normal, and on the right side, it predicted adenocarcinoma of the left lower lobe. So it was as a pilot model or as an initial model, it was very good. Now, when we look at the literature, now currently it is recommended that artificial intelligence can be used in lung cancer screening. The recommendation on lung cancer screening is that high-risk patient needs to be screened annually with low-dose CT. So here we can see that these are the various studies that have been done on use of AI in lung cancer screening. So they have used convolutional neural networks, then they have used dynamic Bayesian networks, the DBNs, and deep learning models have been used. Then data set is also quite nice. Like here you can see that 5,402 patients were involved, and here near about 1,000, here more than 6,000. This was a training on almost 25,000 lung cancer cases. And just have a look at how it performs. So the area under curve or the ROC was more than 0.75. Now, the more near the one it is, the more accurate it is. So more than 0.75 is really good. Now this model, it performed with a sensitivity of 84.4% and a specificity of 83%. And the subgroup analysis for small nodules less than 10 mm, it showed a high sensitivity specificity. Now this less than 10 mm, let me tell you here that this less than 10 mm nodules, these are very difficult to take biopsy from. These are the most difficult one to take biopsy from. And if in these patients, we can have a sensitivity and specificity by radiology alone of more than 80%, then that's very nice. And again, here the AUC is 0.94. Now that's excellent. So this is near one. Now you can see the reason why this is excellent, because almost the number of cases were 6,000, more than 6,000 cases they have taken. And the validation was done on almost 1,000 cases. So therefore, the accuracy is almost near to 1. So if I want to give one message from this, that how do we develop a good model, is that the number of cases or the number of data sets that are being fed into that model should be huge. So then only its accuracy will be almost near to 100%. Now this is again an ideal model how artificial intelligence can be used for screening of lung cancer. So here what we can do is various blood and tissue data are used, blood serum, antibody levels. There are multiple omics. Omics means metabolomics, transcriptomics, epigenomics. So multiple blood investigations, multiple extent biomarkers, they can be used. And then you can give the risk factors, like is the patient a smoker? Does he have any family history of smoking? What is his age? Is it age more than 55 years? So these are all the risk factors. And again, this will fit the imaging data. So now the electronic medical record will be integrated into this. And with all these features, the artificial intelligence software will predict the risk of lung cancer, of a particular abnormality on CT scan. So this is how AI is currently being developed and used for early detection of lung cancer, not alone on any single parameter. So it is combining all the risk factors, the investigations, the images, the medical record, past medical history, family history, everything, and then giving us a combined or a comprehensive risk factor for that patient, that what is the probability that this is a lung malignancy. Now this is a gold or the current latest 2025 recommendation. There they said that the common risk factors for development of lung cancer are age more than 55 years, a smoking history of more than 30 pack years, presence of emphysema on CT scan, that means certain air tracking is present on the thorax, a presence of airflow limitation, there is some abnormality in the lung function test, okay, BMI less than 25, okay, the patient is not obese, and the patient has a family history of lung cancer. Now these are the risk factors based on which we can build up a lung cancer prediction or a screening model. The current recommendation is to use annual low-dose CT scan imaging of the chest to diagnose lung cancer earlier among individuals aged 50 to 80 years with a more than 25 years smoking history. So the current gold guidelines, now these are the standard international guidelines. What they recommend is that for patients aged or normal persons who are aged between 50 to 80 years and they have a history of smoking 20 pack years. Now one pack year is if a patient smokes one pack one day for 1 year, then it will be 1 pack year. So like this, a smoking index is calculated. So if the smoking index is more than 20 pack year, and if the patient is between 50 to 80 years, then the patient or the person is supposed to do a regular or a daily or an annual low dose CT scan imaging. That means every year the patient is supposed to go for a low dose CT scan imaging and see if any suspicious nodule or anything is there, which can be possibly lung malignancy. So now this is what is recommended. So here what can be done is that the AI models that we have seen previously, they can be integrated. So this is a open field for research and development of models where this can help us screen lung cancer at an earlier stage. Today in our hospitals, the lung cancer patients that we get, most of them are in the advanced stages. Very rarely we get them in the earlier stages. The reason is that in the earlier stage, the lung cancer, these patients are asymptomatic. The patients do not have any symptoms. So if the patient does not have symptoms, the patient is not going to come to the hospital. And by the time the patient develops symptoms, it is too late. That means the lung cancer is advanced to a later stage. So therefore, as physicians or as chest physicians, the lung cancers that we are seeing in our setup are at an advanced stage, and there is very little that we can do. So here AI can help us detect lung cancer at an earlier stage. Now let's come to another thing, that is artificial intelligence assisted bronchoscopy. Now what is bronchoscopy? It is a medical procedure that allows doctors to examine inside the airways and lungs using a flexible lighted tube called bronchoscope. Now this is an endoscope, it is a camera, it is a light, and it is connected to a screen, and on the screen we can see what the camera sees at the distal end. Now this is inserted through the nose or mouth. It enables us to visualize the various parts of the airways, the trachea, the bronchi, the bronchioles, and we can collect tissue or fluid samples to diagnose lung problems like infections, inflammations, tumors, or any blockages there. So in short, this is a tube, a medical tube that we put in the airways and examine the lungs. Now I'll be showing just a small video to have a overview of how this technology works. Now this is the Atalfdp software. Now here you can see this is the pathway. So this is showing me the pathway, the blue line. Now this is a pathway. I am doing CR or a radiology. Now this is the virtual image, this is the actual image. Now this virtual image is showing it go here, actually I am going here. When I am using CR, I have a diagnosis and I am taking the tissue. This is CR. So a highly accurate decision with use of technology and artificial intelligence. Now here the risk is that if my accuracy is even 1 mm right or left or 1 mm less or more, then I am going to puncture the pleura and I am going into the pleural space. So peripheral lesions, there is a risk of pneumothorax or presence of air in the pleura. So I can get air in my thorax if the procedure is not done correctly. So this navigational bronchoscopy AI-assisted, it helps us increase the accuracy of my procedure, and it thereby decreases the adverse effects or the complication rate of the procedure. So AI can also be used as a co-pilot in bronchoscopies, where a robot is deployed in the clinical setting for bronchoscopic procedure. So it can help guide me, or it can work with me in a bronchoscopy. So here, intelligence of operator, the skill set of an operator and the skill set of an AI, they are combined. So this was published last year. So this is called as AI co-pilot. Now here what is used is a bronchoscopy robot is used. It is basically a arm where a catheter is there, and then through that the bronchoscope is there. So near the patient the arm is there, and the operator, he sits on the console. So the control is shared. So AI and human shared control is there, and the decision is taken by the algorithm, which is trained over a large data set. So how it works is, the robot and doctor are working together. The robot takes pictures during the procedures. The doctor gives command to guide the robot. The AI will use these pictures and commands to decide where the robot should move. So the robot will take a picture. The doctor is here. He will give commands, and then an integrated algorithm is there. That where the decision, where the maneuvering or the moving the bronchoscope will be there. The AI makes sure that the robot stays on the track to avoid mistakes, working with the doctors to stay safe. So the technical point here is that the bronchoscope will stay in the center of the airways. The AI will target that it will be in the center of the airways and it will not touch the periphery or the walls. So how the training is there? It has been trained on various 3D models, and here the main job of the doctor is to guide the robot, and then the algorithm will take an integrated decision. So this is the procedure how it works. A bronchoscope goes inside, the robot puts it, it takes a picture, bronchoscopic image is there, then the doctor will give it the instructions, which button should be there, left, down, right, up, everything. Human command will go, bronchoscopy image will go, and then the algorithm will predict that where actually the bronchoscope should move, and then it will be a steering action, and then the feedback will go again to the bronchoscope, and the bronchoscope will advance. So this is a very simplified algorithm of how AI Copilot works in integration with the doctor's commands. Now this is an example of our case. So this was a medical thoracoscopy which was done by me at Ih&Ms Nagpur. So here on the left side you can see that this is a very bloody field. So everything, this was basically a suspected case of malignancy. So in malignancy bleeding is there. So in this bloody field I have to take a biopsy from this nodule. Now using technology there is something called narrowband imaging mode. So when I turned it on, then you can see that the bloody field is almost removed. It is just a image enhancing feature of this scope. So when the bloody field is removed, you can really see the nodule very nicely and the vascularity. So these white lines, these are the blood vessels, and this is the malignant nodule. And from there, from this malignant nodule, we took a biopsy, and here the report had come that it is a malignancy or cancer. So this is how the current technology is being used. Now this is just image enhancement feature that we use. Let us see how it can be integrated with AI. So now this is a ongoing project. So the various research is going on in this field that this narrowband imaging can be integrated with artificial intelligence, and then it will give me a probability that yes, what is there are 2 or 3 nodules. So I should take biopsy from which nodule, where the chances of bleeding will be less and the chances of having a good yield will be high. So the chances of having a good histopath diagnosis will be more, and the chances of complications will be less. So if I train a model, AI model based on various data sets, so it can help me in this decision-making process. So the integration of AI with MBA is a developing area, offering the potential to provide diagnostic assistance by analyzing images with superior accuracy to human experts. So in image analysis, it can help, thereby supporting endoscopists, reducing the diagnostic errors and possibility, thus standardizing interpretations. Okay, so this combination can significantly increase the diagnostic performance, and as I have already said, and it can improve the patient outcomes by decreasing the complication rates. So this is a very nice and very useful integration area of medical technology with AI for the future. So what is the role of AI in enhancing narrowband imaging? It can be used for superior image recognition. It can help us standardize interpretation. It can give me an increased accuracy and efficiency, and it can help me in diagnostic assistance. So here for image recognition, deep learning models, they excel at pattern recognition, and in various studies they have shown to surpass human ability in complex image tasks. And again, it will help in standardized interpretation. That means when 2 doctors are interpreting the same image, there will be a difference of opinions. There has to be a difference of opinion because no 2 minds will think alike. But when I involve the AI, there will be a standardization in interpretation because it is being based on data sets. So it will use algorithms and maths. The accuracy and efficiency will definitely be increased, and what the current pilot studies have shown that it exceeds those of expert endoscopists or human errors are decreased. And diagnostic, it will definitely help in diagnostic assistance. Real-time feedback during the process will definitely be of help, and small features can be recognized. So it will reduce the delays and the errors will be minimized. So the potential benefit of MBI plus assisted this artificial intelligence thoracoscopies, it will improve the diagnostic accuracy. If I need to take a biopsy from a lesion, it will give me enhanced biopsy guidance. It will pinpoint the suspicious areas, and it will make the procedure more safe. And it will increase the accessibility. Of course, it will help in decision-making process to the clinicians, and it will expand my access. That means currently, if I have limitation that I will not touch certain tissues with a higher risk of complications, I might advance that also. So it will give me more access to more tissues and at a higher safety. Now coming to the next area, that is use of artificial intelligence in tuberculosis detection. Now this is coming up in big way because TB, it is a disease that is in a very high proportion in our country. We are in the global top 3 countries in TB disease and infection both, and we are on a war footing to eliminate this disease. But the scenario is such that almost 26% of the world cases are in India. Drug resistance TB is quite high with us. 1/3 of the global population and the Indian population, it is infected with TB infection. So every third person is infected with TB infection. That means it is not manifesting in the form of disease, but the organism have sometimes entered in your body, and you are showing a positive immune response to that. So therefore, this is a very difficult challenge, and AI will definitely help us. Let's see what are the current avenues of AI integration in TB detection. So natural language processing for TB symptom screening. This is the first thing. So currently in my OPD, if a patient comes, I need to give almost 10 to 15 minutes at a minimum to analyze or to take the history. Then I'll take analysis, then I'll do analysis, and then I'll order the investigations. And after investigation comes, I'll do a clinical or clinical correlation and then advise treatment. Now this symptom screening is something that can be decreased with AI. The time of this symptom screening that can be decreased, and faster screening can be done. So what AI-powered symptom screening does is it analyzes patient-reported symptoms and clinical histories. It can identify presumptive TB cases. So if I go in the community, it will identify presumptive TB cases. Right now on Midan TB or community project, it is also using AI. It has speech-to-text recognition. That means no one will have to write anything. So softwares already they are present that I'll dictate it, it will take notes, it will do everything, it will analyze, and it will give me a feedback that yes, this is a presumptive TB case. So it facilitates the continuity of care via better digital linkages. Now this is one platform called the Swasa platform. This is used by Government of India in some areas. This is a patented technology. What it does is, some of the features of this is that it records cough sounds via smartphone microphone. It analyzes the unique cough signatures for TB detection. And it is a non-invasive rapid mobile-based screening, especially valuable in resource-limited settings. So now this is a new technology. So what the patient can do is, he can cough, record the cough sound. The software will analyze it, and it is a data set of all the respiratory diseases, like cough sounds of tuberculosis, cough sounds of pneumonia, normal cough sounds. That means the patient doesn't have any disease, but the patient is asked to cough. Cough sounds of any viral disease, the cough sounds of interstitial lung disease, the cough sounds of non-infective disease like COPD. So everything is fed in the computer, and it is made to recognize that okay, these were the patients who were diagnosed with tuberculosis. So that data set is there. So with that data set, the patient, the artificial intelligence will analyze what are the probability of this cough sounds to be due to TB. Again, along with that, it is fed a respiratory questionnaires. Certain investigations can also be fed, and we can make a system where it will analyze everything and then give us a report that okay, what are the probability of this being TB or something else. So as you can see here, that it predicts, current models they predict pulmonary TB, asthma, COPD, COVID-19. So it is a quite utility in the clinical setting. Let's say take the example of COVID-19. In COVID-19, usually airborne infection was a very high risk. So this airborne infection control, this was a limiting factor in taking a detailed history. Now, if we have something like this, which can take history, analyze it, and give me a report, so there is no need of physical interaction. Everything can be done on the basis of phone, and then the decision making or analysis can be done, investigations can be done, and diagnosis can be done. So, in infectious diseases like COVID-19 or TB, this can be of valuable help in resource limited settings or in the community also. Now AI is coming in a big way, as we have seen there in chest X-ray interpretation, specific TB detection algorithms or softwares are there. Now these are some of the softwares like QXR, Cure AI, CAD4TB unit. Now this Cure AI, this is the accuracy is almost 95% in TB detection. Now that's very high accuracy for a software to be there. And the impact is that in India, this is used at certain sites. So there is 30 to 40% increase in case notifications. Just because these cases could have been missed earlier, the software is picking them up, and it is increasing the notification rates. Almost 1,20,000 patients have been screened across 113 facilities in the past. Now this is currently being used. The CAT for TB, this is again another software. 32 million people were screened. The speed is 5 seconds per X-ray. So in 5 seconds, when X-ray is taken, it gives a probability score in percentage, something similar to what we are using. And they say that it is superior to human readers, basically in terms of speed, because it will be very difficult. If you ask me that I read an X-ray in 5 seconds, it will be difficult. So it will take me almost 1 minute to 2 minutes to read one X-ray. If I the fastest that I can try. And this is the Lunit Insight HS X-ray. The top ranked among all the 12 AI products. This was published in the Lancet Digital Health. The area under curve is almost 0.902. So it is very near to 1. So it has a sensitivity of 89.9% and a specificity of 68%. It meets the WHO target profiles for TB screening. So these are the various softwares that are currently available in the market. So machine learning in TB diagnostics. So again, another area where this machine learning can be used or artificial intelligence can be used is sputum microscopy. So what is sputum microscopy? The sputum of or the cuff expectoration of the patient is collected, and usually the conventional method is that the sputum is examined in the microscope. Now that microscope can be attached with the software with artificial intelligence, and that software can detect, it can examine the various slides and it can give us the result. So these are the various softwares that are developed in that domain. So microscan 2, now this has a sensitivity of almost 87.7% and specificity of 96%. Negative predictive value of 87.8%. And again, this can be remote operation by internet. So this is useful in resource limited settings. Again, considering the airborne infection control measures, this is decreasing the patient and the healthcare worker physical interaction. And with such a high density and specificity, these are really good softwares. Again, there are other softwares which have a sensitivity of 91 or 92% and 98% with accuracy of 96.7% for conventional acid-fast specialized. These are the conventional microscopy. And in molecular diagnostics also they can be used. These are the various forecasting models, random forest and wide deep neural networks. So these are the forecasting models, and it predicts the antibiotic resistance. So if the treatment or the drugs that I am giving to the patient, will that be useful or not? So this next generation sequencing or this sequencing is something that it will analyze the sputum sample. It will give me detect the bacilli, and it will give me the various mutations. These mutations runs in thousands. If I do a whole genome sequencing, it will run in hundreds to thousands. It is difficult for a human to pinpoint all the mutations. So right here, softwares are used to take the important mutations or the clinically significant mutations, and then they are read with the WHO catalog or the national catalog that we have. Here, if we have the AI like this GenTB, so that can be of quite help, and it can increase the sensitivity. So here the sensitivity is 77.6 to 75.4%, and it just gives, it does not detect the drug alone. It will give us whether the TB bacilli is drug resistant or drug sensitive, and which drugs I can advise to the patient. So such a thing is really helpful for the physician. Now again, let's come to something AI designed antibiotics. Now previously this was a domain of the human mind. Right now this is a research that was almost published recently. Almost on 23rd August, this news came out. So just a couple of days back. So this is the Massachusetts Institute of Technology. There the researchers have used generative AI to invent 2 novel antibiotics. Now coming up with 2 novel or completely new antibiotics with completely different molecular structures. This is really fascinating. And what they have done is these antibiotics. These are effective against drug-resistant gonorrhea. This is the STD or genital disease and sexually transmitted disease, and MRSA. Now this is MRSA is nothing but methicillin-resistant Staph aureus. So Staphylococcus aureus, this is one organism, and methicillin resistant means these are basically drug resistant bugs. So why this is important? This is important because this MRSA pneumonia in hospital, the mortality is 31.2% compared to pneumonia with other etiologies. That means if 100 patients are admitted with MRSA pneumonia in hospital, then 31.2% patients will die. And similarly, compared to other pneumonias, there 11.6% death rate is there. So this is a high a bacilli with a high mortality rate. And here developing novel antibiotics with the use of AI. This is really the genius of AI. So right now the focus has shifted from screening compounds to designing molecules. Previously they were screening the compounds. Now these two molecules, these two antibiotics, they have been designed right from the molecule stage, right from the atom stage. So they have started from the atomic stage, that is just the very basic stage. So it is really fascinating. So just something how the antibiotics were designed. So against the two diseases, gonorrhea and MRSA, they have used the antibiotics. The study highlights how many compounds did they screen. So the artificial intelligence, it interrogated almost 36 billion compounds, including undiscovered molecules. Now this is almost impossible if humans were to do this task. If you ask a human being to screen or check 36 million compounds, it's practically impossible. So their artificial intelligence has done this job. It was trained on chemical structures and bacterial growth data. It learned how molecular structures, carbon, oxygen, hydrogen, nitrogen atoms affect bacteria, and from the atomic level, it started its work. So it was built from libraries of 8 to 19 atom fragments. It removed compounds similar to existing antibiotics, and the molecules which were toxic or relevant, they were removed in the screening process. So AI generated novel antibiotic candidates it found, and after lab and mouse testing, 2 new potential drugs have been discovered. Now this is a paper which was published. Now the original paper, it was published on August 14, so almost this month. So this is a very hot research paper that is currently in the domain of AI and healthcare. So this is just not a simple discovery. The traditional approach was to screen existing compounds, and the new thing is that AI invents novel molecular structures atom by atom by screening millions of compounds. So in the history of medicine, the breakthroughs the traditional breakthroughs were anesthetic, the discovery of anesthetic, antiseptics, antibiotics, and now artificial intelligence seems to be the 4th breakthrough in medicine. Because discovering antibiotics, it is not a small task. Now coming to the role of artificial intelligence in airborne infection and prevention and control and practices. Something related to this airborne infection prevention and control and practices. Let me tell you that in respiratory medicine, this is of prime importance. The importance of airborne infection prevention and control is to prevent the healthcare workers as well as the normal patients visiting hospitals from getting hospital-acquired infections. Because in the hospital, many types of patients come, so the infective, non-infective, they come on an OPD visit, they're admitted in the wards, and the hospital is a very highly infective environment. So if airborne infection control measures are not there in place, then this hospital will be a very high risk for infection transmission. And therefore, this is a very important pillar in any hospital administration. Let's see how AI can help us here. So, artificial intelligence and robotics are currently being used in healthcare disinfection. Integration of AI and robotics is reshaping the infection control practices. It can automate disinfection, reducing reliance on manual high-risk procedures. Like let's imagine the example of COVID-19. In COVID-19, various patients were admitted in the ward. Now, if a healthcare worker were to go and clean the ward, the healthcare worker were inherently to have a very high risk of getting COVID-19 infection because it was highly contagious. So here, if I have a robot which can see through a camera various places and disinfect the high risk places with appropriate thing, then nothing like it. It will decrease the human risk, the healthcare worker risk, the risk of transmission. So that is how this can be integrated. So this is crucial in COVID-like pandemics to protect the healthcare workers from exposure in contaminated areas. Now, I just give a small example of how robotic disinfection is currently being used in healthcare settings. Like there are radiation rooms where if a normal healthcare worker were to go, he'll have to wear various protective equipments, lead aprons, everything in the room. Or if the room is infectious, then again the infection control will be a big issue. So this is just an example of how robotic disinfection with the help of AI can be done. So this is the radiology department where there is a high risk of radiation. Basically, ultraviolet disinfectants. This is a now ultraviolet disinfection of the epiderm. This ultraviolet radiation is undergoing how the human health. Areas, so between one patient and another patient, this can be used, or after one session, this can be used. So this is how currently it is going. But there is one major risk. The risk is that if we are too dependent on artificial intelligence, is there a risk that we might lose our skills? So for examining this again, paper was published recently in the Journal of the Lancet Journal, which is a reputed international high impact journal. So here, artificial intelligence in colonoscopy, what they studied was, it was a multi-center observational study, and it studied the impact of routine AI used during colonoscopies. So two groups were there, one which was using routine AI and the one which was not using, or which was doing it manually. So the key finding was that regular reliance on artificial intelligence may impair clinicians' ability to detect precancerous growth without AI assistance. So if you are regularly using the AI, then the skill set in which the AI is helping you might decrease. So the human skill set might decrease with use of AI. This is what the paper has found. So this is a big flag. We need to be aware of this. That a complete reliance on how far should we go for complete reliance on AI? Because AI and skills both going hand in hand. We cannot, at this stage, we cannot give complete decision making or complete control on AI. It has to be a human AI shared interface. Again, in cases of outbreaks, let's take the example of we have flu outbreaks, we had COVID outbreaks globally 3 to 4 years back. So outbreaks, usually medical or respiratory outbreaks, they spread fast. Hours matter, but data reporting is slow. So traditional symptoms, the traditional systems, how they do this outbreak surveillance is manual collection, labs are there, and with these manual methods, they are reporting delays. And after outbreak has started, it takes days or weeks to recognize the outbreaks. And this delay, this is a critical gap, and officials react to yesterday's data while crisis unfolds today. So the data that is taken to yesterday from the field, that will come to the office today. Today they will be analyzed, and then it will be said that okay, outbreak is there, and we need to take some action. So the conventional method, there is a chances of missed early interventions. The systems are already overburdened. You cannot expect that they do the things faster, because in our country, everything means compared to the disease process, the systems that the healthcare system that we have in our place, it is currently not that robust to handle outbreaks like COVID currently. So sometimes death might occur. So artificial intelligence in epidemiological response, how we can use it? So it can be used in real-time surveillance. AI will scan what it will scan. It will scan social media, emergency hospital responses, mobility, search data, satellite images, everything will be given to it. And then it will detect symptom clusters and behavioral shifts before official reports. So based on various data inputs, it can detect epidemics at a much earlier time than compared to the conventional or currently existing systems. So the predictive power can be used. It can forecast the spread. It can identify that which epidemics are going to spread, which can be contained, which are high-risk epidemics. It will identify the vulnerable groups. That means which population is at risk. And you can do simulates various intervention. That means the policymakers can see, okay, what if I do a complete lockdown? What if I do IEC or that the patient should wear mask? What if I do a social intervention? So various things can be simulated rather than actually trying in the field. So you can simulate those things, you can get the result, and the most whichever is the most reliable thing and the most efficient thing, you can go with that. So historically, these have been used. Now, this Blue Dart was the software that flagged the Wuhan pneumonia in December 2019 before the WHO alert. And Health Map is a software that spotted early COVID signals globally. So this is these are the proven cases. So how does AI support? AI supports early outbreak detection, optimized resource, logistics planning, beds. What it can do is that, okay, the resources and the logistics that I require, the beds, personal protection equipments, vaccines, staff, everything, it will give us. It can give us an estimate. It can give us basically an infodemic control. It can track the misinformation, guide public. So it can, since it is monitoring social media, it can give us everything. Okay, so this is the misinformation. Here the IC activities need to be targeted. So it can give us basically everything that is required for epidemic control. So it can. What is the relevance of AI in forecast models in medical research? So in medical research, we can use AI in various forecast models also. So these are all machine learning models. The Gaussian process regression, the gradient boosting, the state space models, the ensemble models. This is basically a combination of everything. So we can use machine learning models to forecast things for us. Now I'll give an example of this, which I am using. So this is our current study, which is ongoing. So this what we are trying to do is project the trends of incorrect anti-TB prescriptions. This is basically a meta-analysis. This is the first meta-analysis from India, where we have done over the last almost 30 years. So from 1991 to 2024, we had fed the data, and from 2025 to 2034, we are going to predict. So almost we screened almost 7,154 studies. And this was titled the Praman India study that we have done. So we use the various models. So this is the Gaussian process, the gradient boosting method, and the state space model. And combine this with ensemble model, which has a 0.728 this R-square value. So this basically means that in 100 patients, 72.8% patients, the forecast will be correct as per this model. So the forecasted outcomes that we had, this is currently unpublished data, is that the decline in faulty prescriptions will be from 39.1% in 2025 to 37.1% in 2034. So this is a gradual but sustained improvement, but not what the policy would have likened to. So we need policies targeting how to correct the anti-TB prescriptions in non-problematic setting. So this was the data in decade-wise that we had. So from 1990 to 99, it was almost near 70%. Then from 2010 to 19, it was 45, and then 2020 to 24, it was 32%. So we fed the detailed data. These are all the data sets of the studies included, and then the AI model forecasted this for us. So this is absolutely 10 years back. These AI-based machine learning models, they were not present. now they have come up and we are using them for forecasting and using in medical research. So, in the end, what I would like to say is that artificial intelligence is a powerful decision support tool. It is not a replacement for clinical judgment. It is a promising application in imaging, TB diagnostics, and bronchoscopy. The challenges which include our bias, validation gaps, and ethical concerns. Of course, we do have ethical concerns. Public-private partnerships are crucial for scaling AI in TB and respiratory medicine. Now, here the thing is that most of the models, they are being currently developed in private sector, and in public sector, the incorporation of these models, it will take time. So we need some public-private partnerships. Right now, in IGGMC, in our department, we are running we're a part of ICMR trial where a massive data set for the X-ray analysis or the radiological analysis of by artificial intelligence for TB screening is being conducted. So that is a multi-centric trial. We are into it, and of course, millions of data set will be there in the model, and it will be available for free in the government sector. So that is what is required today. So future lies in multimodal artificial intelligence, federated learning, and capacity building. What we require today is equitable, ethical, and scalable adoptions for India's TB elimination for 2025. So in short, what I would like to say is that artificial intelligence, it is coming up in a big way. In the field of respiratory medicine, there are plenty of avenues for screening, for integrating this artificial intelligence. It ranges right from COPD, interstitial lung diseases, asthma, lung cancer screening, tuberculosis, COVID-19, so everything, right? You can help me guide a bronchoscopy, you can help me guide a thoracoscopy, you can help me read an X-ray chest, you can help me read a CT scan, you can help me navigate as per the images. You can help me in airborne infection control. So it's going in a big way. But right now, we are yet not ready for complete AI models because there is ethical concern also. What is recommended that a shared approach should always be there in a healthcare system. Never should we give AI the complete control currently, particularly in treatment, because it is ultimately it is a machine, it is an algorithm. Some errors are expected, and even 0.01% error cannot be. We cannot have the liberty to having at least even 0.01% error in healthcare services where human life is involved. So in future also, the AI has to be coupled with human skill sets or with humans. It should never be 100% AI dependent models. So today, basically, organizations, what we require is AI awareness, AI literacy is a need of the hour for almost all healthcare organizations. And today, the success mantra is AI literacy. So we need to move from current practice to AI-powered healthcare. And that is the reality, and all of us need to be update ourselves with this AI. So, thank you. Okay. Yeah.
Good evening, doctor. Can I have a question, please?
Yes, please.
You have talked about the use of AI in the development of new antimicrobial agents. Can you tell me any softwares, particular softwares which are used for the same?
AI in the development of
New antimicrobial agents.
antimicrobial agents. Okay. So the study that I started was from MIT, Massachusetts Institute of Technology. As of now, commercially available softwares are not available for antibiotics. So what they had done was based on machine learning models, they had developed it by themselves, It is currently not available commercially in market, as per what I know the software that they have used. But
So another question. I got
yes,
it, sir. Do you think, as a physician, do you think that AI leads to the de-skilling of physicians?
yeah. So de-skilling, right?
Yes, 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 yes.
Yes. So that was the only paper that I could get for de-skilling. What they had, I just tell that paper in short. What they had done in that paper was they compared two groups. So one which was doing it and one which did with
I
AI.
got that, doctor. I got that. I understand that completely. I want your personal opinion. I want your personal opinion because you are using the softwares, you are using the AI for getting towards the conclusions.
Yes, yes. So definitely, no. My opinion is I concur with the study because if I use AI assisted technologies continuously, let's say for 1 year, 2 year, and then you ask me to do a AI non-assisted procedure, so definitely I'll fill that void. That okay, now for 1 year I was getting the help in assisted things. So after 1 year, if you tell me, definitely it will be difficult for me to do it without AI. So I'll be much used to that. So again, reskilling or developing back the skill, it will take some time. It is not that it will go permanently, but it will take some time. I need to do it without AI for considerable time to again regain that lost skill.
Thank you, doctor.
Good evening, sir. I have a question.
Yes.
I want to know that we have various performance matrices for AI algorithms like accuracy, sensitivity, or specificity. So while using these AI models for medical application, so usually what is emphasized, like accuracy or specificity or sensitivity?
So it has to be a balance of both. I'll tell because I'll tell it in very simple terms. That being a physician, what I want. So what I want is that it should the sensitivity and specificity of any test should be more than 80%. Now it depends that the test that I am developing, it is used for what? If it is used for screening purpose or it is used for diagnostic purpose. If supposing if I am developing a test for screening purpose, then there I would like a highly sensitive test. That means if I take a population, the test has to be highly sensitive. But if I am developing a test for diagnostic purpose, that means my suspicion is there, but I want a specific diagnosis. It should not be mixing the diagnosis. So where I am using for, I want for diagnostic purpose, there specificity is required. So for screening purpose, sensitivity, and for diagnostic purpose, specificity. But if your overall test is required, then both sensitivity and specificity, they should usually be more than 80%.
Okay, sir. Thank you so much.
Okay, so there is a question. Okay, so we have questions in the chat box. What role will multi-omics plus AI integration play in personalized respiratory medicine? Okay, sure. So multi-omics, this is a new term that included in the study. So genomics, proteomics, and imaging. So these are basically metabolomics. So you take certain blood and biomarkers. These biomarkers could be anything. This could be exhaled biomarkers. In respiratory medicine, the thing that we are developing now is exhaled biomarkers. I'll just give an example of this. That conventional thing for diagnosing, let's say, tuberculosis is taking a sputum sample. For lung cancer, it is a tissue biopsy from the lungs I take. Now, we are moving towards exhaled biomarkers. So there are certain markers in my breath that will mirror the disease process in my lungs. This could be volatile organic acids. This could be any other markers. It could be any chemicals. which I am trying to pick up. So when it is used, so when I use these extended biomarkers along with something like imaging, like CT scan, so the prediction accuracy will definitely be high. So in medicine, we say that no two patients are exactly the same. Usually, the things in every patient is different. So if we go by all these things, if we integrate the genomics means the genotype of the patient, the genetic basis. It is basically your hardware, the hardware of your body, what it is made up of, what are your genes made up of, what are the different characteristics. So each gene has specific characteristics. So each body has a specific risk for a specific disease. No two persons will have exactly the same risk. So many of things we have discovered. Many of the things these are still to be discovered. So when we combine everything, all these metabolomics is the markers which are related to your metabolism. Genomics are the markers that are related to your genetic genotype. Imaging is definitely your the various radiological images, like X-ray, CT scan, these are MRI, these are the imaging. And when we combine this, then we can help go towards a specific diagnosis. We can have certain treatment markers for monitoring. If I develop some index, I can monitor that while on treatment. And if the index is decreasing, I can say that yes, the patient is responding to my treatment. So this is how multi-omics plus AI integration work. Okay, we have again 3 questions. Could you please recommend some reliable sources or websites where you can find relevant data sets, especially those specific to Indian healthcare system? Okay. I'll answer this, but first a big caution. In the lung cancer screening, the CT scan data sets were used. Okay. So there, as a startup, it was good, but the thing was that why its reliability was not as per the physician's expectation. So the thing is that the data sets that are available there, they were just representatives. So as I had said that in a CT scan, there are more than 100 slices. So like what the CT scan does is from your top to bottom, it takes slices of the images and then it presents them on on the report. So if a nodule is present in at some form in a particular slice or 2 or 3 slices, it is not present in upper or lower slices. And if you take the slice for reporting from a normal area, then the report will be wrong. So the data sets that you are supposed to take has to be complete data set. Now this complete data set, this is not available freely on website because of course of ethical issues. For this, you will have to communicate with a healthcare institute, take ethical permission, institutional ethical committee permission will have to be taken, and only then data set of a particular patient or person can be shared with you with the consent of that patient. Because sharing any data set of any patient without the consent of the patient is unethical as per the current norms. But country-wise data you can have on various we have various national portals. You can go in the website of the epidemiological CDC India. So they have various mapping. Then we have the health map website. So there, the health map website, it will give you the correct, exactly the same data. I'll share my screen. I'll just give you an example of health map. Just a minute. I'll share my screen. So this is the health map website. You can see here. Now here you can see that it is telling me 39 alerts for the locations. Now this is Nagpur. So here no alerts are there. This is just telling my location. If I submit here, this will give me the various alerts. And So here, if I search, then it will give me the alerts from the past week. Coronavirus surveillance. So let's see the coronavirus surveillance here. So this is the a global website. So see, so when I click on a specific picture, now this is a here. So from India right now, currently 46 alerts for coronavirus surveillance near me. Not that much, but these are the areas of outbreaks. You can see in the red. So here near China is there, in USA it is there. If I click it here, so it gives me 35 tested positive for coronavirus. This is Nepal, in Nepal. Okay. So this is a global. So this is similar websites available for India also. You can go on the CDC website. They will give the Government of India website also. They monitor the various scenario and they give live versions. And then there is a WHO website. So all these things you can have a So all these things you can have a live picture. So these are the websites, but getting patient-related data online, that will not be reliable and not be ethically permissible. So for this, you will have to go to a health institute. Next question is, even if an AI model demonstrates high accuracy, how can we ensure its reliability for disease diagnosis? What factors should be considered before trusting AI-based diagnostic systems? So it is training. AI model is basically developed in two stages. One is the data sets we have to give, and after giving data sets, it has to be trained. So both is data sets as well as training, they have to be there, and then it has to be compared in a clinical trial or something, a research study. That means the gold standard will be human interpretation or human management, and with that you will have to compare that. Supposing it outperforms, then you can use that AI in integration with human skills. Because today also, if we have AI generated reports in X-ray, there is a small asterisk notification below. This is only for study purpose. For reporting purpose, please take official report from radiologist. As per the rules and laws in our country, AI is not permitted to issue medical reports legally. So it will give you interpretation, but with the asterisk there that officially you are supposed to take report from a radiologist only. And AI is made to assist radiologists. So officially AI cannot issue report. It cannot sign or issue authorized reports. So I'll not advise interesting 100% AI algorithms. They can be used in conjunction with human skills. How can Indian data sets of EHR be created and made accessible for research innovation? Are there any existing provisions, platforms, or regulatory guidelines in India that support? Okay, so electronic health records, basically, currently the National Medical Commission, that is the regulating body for medical colleges in India, it has made it compulsory that electronic health records should be there in every medical colleges. So medical colleges are they're highly rich source of data. And it is in the process in our country. Once a medical college hospital has electronic health record system, it is very easy to get access of that data. You need to contact the or collaborate with the healthcare systems there or the healthcare professionals there, and then unified research can definitely give you access to data. But a permission of institutional ethical committee is always required, because these data sets, these are not freely available. They have to be sought for and permission needs to be taken, and basically institutional ethical committee is there, that permission is required. Are there any case studies of successful implementation of AI in diabetic diagnostic research? Okay, so diabetes is not my research area, but definitely they can be looked into. In diagnosis, you have the diagnostic criteria of diabetes. These are based on fasting blood sugars, hemoglobin A1C. So if a software is there, it can help you say that, okay, so diabetes is diagnosed. So diagnosing diabetes currently in medicine is not that difficult. You have very objective parameters. You have fasting blood sugar, you have random blood sugar, and you have HbA1c, glycated hemoglobin. So this can be done, and a simple diagnosis can be done. So research will not be required here, but it will be required in pre-diabetic conditions. The next question is, what are the biggest limitations or challenges you face in adopting AI tools for respiratory medicine? Okay, so biggest limitations or challenges. Again, there is a question at the back of my mind whether the reading that it is given is reliable or not. So always the thing is that I trust my instincts, I trust my decision, and I will use the AI to supplement it. Supposing that if at any time, if my decision is going cross with the AI, so I will search it, I will take an evidence-based decision, and then go forward. So I'm always open to improvement, but I will definitely go into the root cause. I will not take AI decision just by the face value of it, because currently they are in not in the advanced stages of development; they are in initial stages of development, and errors can occur with any software. Okay. So which AI machine learning algorithms is used to predict the exact decision in terms of multi-omics biomarker? Okay. So I've not gone in detail through the paper, but that paper is available on the net. And just a minute. Just a minute. I'll go to the multi-omics paper. Yeah. So the multi-omics paper that was published in the Journal of Clinical Medicine. I'll give you the chat box the reference to that. So you can go through that paper. I'm giving the reference in the chat box.
Okay, thank you, sir.
Yeah. So this is the reference paper. You can go through this. Okay. And what are the biggest? Okay. Is histopathological images can be used to detect lung cancer? Yes, definitely. So this is a very good question asked by Mr. Ayaz Khan. Is histopathological images can be used to detect? Yes. So the diagnosis of lung cancer, it is basically not image based. It is basically based on histopathology report. That means you take a tissue, you take a tissue bit, you examine it in the microscope, you undertake some biomarkers test, you take some mutation studies in that, and then you diagnose the exactly what type of lung cancer it is, what is the typing subtypes of it, and it will respond to which therapies. So it is basically lung cancer is basically a histopathological diagnosis. Now, what this AI learning algorithms can do is that they can take the CT images. On CT, the diagnosis is never confirmed of lung cancer. What they do is you can take a CT images, you take a histopath diagnosis, you take a biopsy from that, and once the biopsy comes, so ideally for developing an AI model, you need to have two things. One is the CT report, and one is the histopath confirmed diagnosis. So all the patients in whom you have histopath confirmed diagnosis, you can take the images of that, and you can correlate with CT, and then you can develop a model that based on back learning that based on CT, it will predict what type of image is possible on microscopy. So that will be the typing of your lung cancer. And histopathological images, yes, histopathological images alone you can use them. You require a collaboration with the pathology department. Pathology department will can give you the slides that okay, so these are the different types of cancer. You need to take the images. Now the softwares are there which capture the images from microscope, and you fit the diagnosis in the AI software. But the data set needs to be used, not just 20, 30. It needs to be in hundreds and thousands. Then only it will be able to recognize. So the microscopy based AI systems I had given reference to, such systems can be they can be developed, and along with histopathological images, you can also develop the CT correlation. So that is what is the highlight of research nowadays. That you give a data set to the machine of histopathological images in CT and tell the machine to predict the histopathological images of the type of cancer based on CT image. Okay. I'll again see.
Doctor, you have, for example, you have concluded a pulmonary malignancy with the help of AI. So can you use this data set to teach your AI model?
The project, the short project that you are saying that I have shown.
Yeah.
Acha, huh. No, that is basically a very raw stage. The limitation of the study was that the students they used a single CT image. They had used ready-made, which were available on the internet. So they used ready-made CT images, and from there they used. So that CT image, it was not representative in the whole picture. What was used there was that from the whole city they used one image in which the malignancy was seen, and that too. Let me explain like this: as CT is it is a 3D structure. Means you are looking at a 3D structure in a 2D image. Okay, and you are having slices. So, like, like supposing if this is my lung, okay, I'll take a bigger lung. Okay, now. So, supposing if this is my lung, bigger lung, and a nodule is present here. If a nodule is present here, if I take a slice here, then only I'll see it. Okay, but the nodule is not the same everywhere. At the top, the nodule is small. In the center, it is big, and in the again at the bottom, it is small. So what will happen is that if I take the photo of the nodule from center and I say to the AI that okay, this is a lung cancer. So and at a later stage, if of the same CT image, I give the top part, which is small, it will say no, it is not matching in that picture. So this is not cancer. So the drawback of that study was it had taken a single image. It was not taken multiple images. So therefore, it was not that high. So whenever in future we take, it has to be from a hospital, from actual patients, and all the sections have to be taken. In a CT scan, more than 100 sections are there. So all the sections have to be taken, and we have to pinpoint that this is normal, this is abnormal. We have to have a histopath diagnosis. Okay, so this is a histopath diagnosis. This is adenocarcinoma. I will link that with the nodule, the small round mass. That okay, these pictures from the top to bottom. This is a nodule. This is abnormal. These are normals, and this abnormality on microscope it was adenocarcinoma. And only when I link it that way will I get a reliable result. So there are two drawbacks. They had taken a single image which was not representative of the whole nodule, and they did not take histopathological confirmation. They had taken just from the data set. So it was not that clear. But as a starting point, I had given them the feedback. So as a college project, it was okay. But if we need to really develop good models, they need to take the whole images of a CT scan, more than 100. So we need to develop it right from the start.
Thank you very much, Doctor. Thank you.
There is a question, do we need to take medicine if you are tested antigen positive? Okay. So it depends on what disease you are thinking of. Let's say this is what sample. Okay. Now this can have different meanings. So I will take the example of COVID. Okay. So in a COVID, if there are different guidelines, the basic dictum in medicine is do not treat the test, treat the patient. Okay, that means if the patient has symptom, your treatment should be guided towards that. So in COVID, the guidelines said that if the patient is antigen positive but the patient does not have any symptom, then these viral illnesses can be taken care of by your own body if you are immunocompetent. If you do not have any immunodeficiency, or if you do not have any comorbidity, like if you do not have any diabetes, do not have hypertension, you do not have obesity, you are not pregnant, you are not having any other disease like sickle cell. So if you are healthy individual, then there is no need of taking medicine in absence of symptoms. Even in presence of symptoms, the guidelines said manage symptomatically. But if you had symptoms or if you had comorbidities which increases the chances of death or chances of complication, then there you are supposed to take the medicine. So it is basically the symptom, the clinical profile, everything that detects whether to take a medicine or not. And it is not just an antigen test. Okay. I think questions are. I think the questions are, all the questions are taken care of.
Yes, sir. Thank you so much, sir, Dr. Gyanshankar Mishra, sir, for sharing your valuable insights on the use of AI in detecting lung cancer, navigation bronchoscopy, TB detection using NLP, use of machine learning and TB diagnostic. So it was a highly informative session, and we truly appreciate the time and effort you took to enlighten us with your research work, past and current projects in respiratory medicine. Indeed, sir, your talk has added a great value to our FDP. Thank you so much. Thank you so much.
Thank you again. And I especially thank Professor Khatib for inviting me and the organizers. It was really nicely, a very nice session. And I really like the nice interaction at the end of the session. It was really nice. Thank you.
Thank you so much, sir. Good night. Any instructions for tomorrow, madam?
So all the participants are requested to submit the today's feedback form for both session 1 and session 2.